Hello, welcome to the channel Nursing in Handy. This channel is preferably for the nursing fraternity to have a continuous learning in the profession. So today we'll be seeing about organization of a special care neonatal unit or a intensive care unit. So before going into the topic, we must know what is mean by special care neonatal unit. So this is a unit which is being given a special care to all the neonates depending upon their gestational age when they are born and the birth weight, and also some of the babies who require a intensive care rather than a home based care. So for that babies we are going to give a respiratory support, cardiovascular support. That means we are going to give in simple term a ventilator support, thermoneutral environment to the babies. If the baby is having hyperbilirubinemia, we are going to give a phototherapy to that particular baby, or if a baby in need to do a exchange transfusion. For these all purposes we are going to give a intensive care, that is special care to the babies to increase their survival and also to aid in additional support to the babies in terms of all the diagnostic or the treatment purposes. So we are going to see in detail about what are the levels of care. That is, level 1 care means what, level 2 care, level 3 care, and also we are going to see how the neonatal intensive care unit, that is a special care neonatal unit, should be located, how the proximity should be, how the physical structure of that particular SCNU should be, that is special care neonatal should be, and how all the acoustic features, radiotherapy unit, incubator unit, and for each and every bed cubicle of that particular newborn, how much space should be there, how the noise control should be there, how about the sterilization should be there. That is, that particular region is depending upon the level of care. There is a sterile region, how we have to maintain those sterility in that particular area, how we have to encourage the, even if the baby is being admitted in the special care neonatal unit, how we are going to improve the feeding for that babies, either expressed breast milk, or how we are going to give the kangaroo mother care to the babies. So for each and every special care neonatal unit we are having that levels of care and also treatment and diagnostic modalities and physical structure of that special care neonatal unit. We will see one by one in detail. Organization of a good quality special care neonatal unit is essential for reducing the neonatal mortality and improving the quality of life among the survivors. So the Government of India has launched an initiative to establish special care neonatal units at district hospitals to provide the following services, that is care at birth including resuscitation of asphyxiated newborns, management of sick newborns, referral and transport services for the babies needing mechanical ventilation and major surgical interventions, postnatal care and immunization services, follow-up of high-risk newborn. So in every district hospitals, the government of India has launched a special care neonatal unit in order to provide the special care to the babies for this, to increase their survival and aid in all the respiratory and the cardiovascular support, that is ventilatory support. So who and all babies who requires this support is like asphyxiated babies, or the babies who's born with the congenital anomalies and they require a surgical intervention. For these all babies we are having a district hospitals with special care neonatal units. So levels of care, the India has the 3-tier system of level of care based on the gestational age and weight of the baby. So level 1 care is for the newborns whose weight is about 1800 grams and the gestational age is about equal to or more than 34 weeks. So these babies requires a basic care at birth, provision of warmth, maintaining asepsis, and promotion of breastfeeding. So this type of care can be given at home, sub-centers, and primary health centers. So this is a level 1 care who does not require any intensive care, who does not require any special care, comes under this level 1 care. And the babies who's born with 1800 grams and gestational age above or equal to 34 weeks is considered as a level 1 care. Next we will see about the level 2 care. Here the neonates whose birth weight is about 3200 to 1800 grams or the gestational age between 30 to 30 weeks are considered under this level 2 care. And for these babies we have a trained nurses and pediatricians, and the main facilities and functions being carried out in this level 2 care is the equipment for resuscitation, maintenance of thermoneutral environment, intravenous infusion, gavage feeding, phototherapy in case of the babies having increased bilirubin level, and exchange blood transfusion. So this type of care can be given at first referral units, district hospitals or a teaching district hospitals. So this is known as a level 2 care. That is the, again I repeat, the weighing of the babies, that is between 1200 to 1800 kilograms, and gestational age between 30 to 34 weeks. And these are the main functions being carried out in the level 2 care. So our main intention is to provide a resuscitation support, thermoneutral environment in case of hypothermia, because the newborns have a heat loss mechanism from their body through radiation, everything. That is level 2 care. Now we'll see about level 3 care. Here the neonate's weight is about less than 1200 grams or having a gestational maturity or less than 30 weeks are categorized under this level 3 care. So here it is the heart of the institution which provides a care for this, specialized care for this level 3 care. So what all care will be given is mainly there to support their oxygen, suction facilities will be there, servo controlled incubators will be there, vital signs monitor in case of they have unstable vitals, transcutaneous monitors will be there, ventilators to support their respiratory and cardiovascular functions, infusion pumps. So the babies who's born with congenital anomalies or if they require any immediate surgeries, they should have a intravenous fluid administration, and the babies who require the drug administration through infusion pumps. So for these all the cares being given in the level 3 care, it is intensive care. For this level 3 care, the trained personnels, trained intensive care nurses, trained intensive care pediatricians or senior residents should be there for this level 3 care. So these all are the 3 levels of care, 3-tier health system. Next is space. How this special care neonatal unit should be. In a maternity unit having 2000 deliveries per year, facilities for special care of 6 to 8 high risk infants should be available. So in the hospitals which conducts 2000 deliveries per year, it should have access for giving the support, that is survival support to the babies, that is high risk newborns of about 6 to 8. Next is each infant should be provided with a minimum area of 100 square feet. For each and every cubicle there should be 100 square feet. Why we are giving 10 meter square spaces? Because it will be having their own tubings, feeding area will be there, and a medication administration area, vital signs monitoring area will be there for that purpose. There should be no any compromise for the space to reduce the nosocomial infection and also the cross infections between the babies. So from one baby to another, we have to prevent the infections. For that purpose, we should have this adequate space between the babies. So this is the space criteria for the babies in the 3 levels of care. For level 1 care, it does not require this much. For level 2 and level 3 care, and even in level 3 care, we have a separate bay for the high risk newborns. For that purpose, we should have each and every cubicle there should be 100 square feet of gap. Space should be there between each and every newborn. That is a space. So next we will see about location, where the special care neonate should be located. So the neonatal unit should be located as close as possible to the labor room and obstetric operation theatre to facilitate prompt transfer of sick neonate. The presence of an elevator in close proximity is desirable for transport of outborn babies. So for example, the neonatal care unit should be located beside of the obstetric operation theatre or labor room. Why? Because when a baby is born, if we will, as a nurses, we will be assessing their Apgar score. If there is abnormal Apgar score or the baby requires the immediate support for the respiratory and ventilatory support, we have to shift the babies from the obstetric operation theatre or the labor room to the special care neonatal unit, depending upon their conditions, either level 2 or level 3. To have that safe transfer of the babies, we should have a close proximity towards the obstetric operation theatre and labor room. And in same way, there should be elevator in the close proximity. Why? Because if the baby is coming from other hospitals for the care in this particular level 2 and level 3 care, we should have that proximity to easily shift the babies from the casualty to the special care unit. Next is design. How it should be. The design of that particular unit should be in a square space, because if it is square only, we can utilize the major areas, major physical structures of that hospital. Next is a single corridor based rectangular unit. There should be a single corridor in the special care neonatal unit. Why? Because if there is a many access of the people towards that particular neonatal care unit, then either the medical personnel will have a hectic work in just segregating the patients, and also the patients will have confusion towards where they need a prompt treatment. They will confusingly come to the neonatal unit. So in order to avoid that, we should have a single corridor to have only a limited access of the people or the mothers or the caregivers who are being admitted in that particular special care unit. Next is a split unit should be avoided to prevent the infections in the hospitals. Next is baby care area. So the unit should be provided with areas and rooms for inborn or intramural babies, step down nursery or outbound or extramural babies. Examination area should be there, and mother's area for breastfeeding and expression of breast milk. Nurses stations and charting area should be there. Obviously, infected infants with open sepsis, that is about some of the conditions like diarrhea or abscess formation is there, means those babies should be isolated from with the other high risk newborn babies in order to avoid the cross infection or nosocomial infections to other babies. So in order to avoid that, we are going to isolate the sepsis babies from the special care neonatal units. So the nurses or the pediatricians who's handling the open sepsis cases like diarrhea and abscesses, they should not have access towards the other babies, other high risk newborn babies in the special care neonatal unit. So there should be a difference of nursing staffs and the medical professionals for open sepsis cases and other high risk newborn cases. So we should not mingle those two cases. Next is there should be a separate area for the examination room. That is, a comfortable seating arrangement should be made, and that should have an examination table, comfortable seating, sufficient lighting to have a proper inspection visualization. Warmth is needed for the assessment for baby before admission to the nursery, and there should be a separate area for the mother to give a breastfeeding and express breast milk. Next is hand washing and gowning. So since this special care neonatal unit is a sterile area, we should have a separate bay for hand washing and gowning for both medical personnels, that is nursing personnels and medical personnels, as well as the caregivers who visit the babies for various purposes like kangaroo mother care or giving the expressed breast milk. For that purpose, we should have a hand washing area. So that hand washing area should have a elbow operated taps rather than a finger operated taps. Then only we can maintain the sterility in that particular region. So we should have elbow operated taps, and also there should be a dispenser, soap dispenser for doing hand washing, and also there should be a separate slippers. So when from outside we will be wearing one slipper, when we enter into that special care neonatal units, we will be wearing that nursery slippers. So these all are the facilities being available in the special care neonatal area before entering into it. So there should be a special hand washing and gowning area. And the same way, where we are doing the hand washing, there should be a sticker which tells you how to do the hand washing. So as a medical personnel, we will be doing the proper sterile hand washing. So when a mother or a caregiver who comes inside those special care neonatal unit, they should know the awareness regarding the hand washing and the importance of hand washing before entering into this area. So that is being provided in the hand washing and gowning area. A unit should be provided with 24-hour uninterrupted water supply by having dedicated over tank with the capacity of 1000 to 2000 liters of tank for dispensing the water. That is uninterrupted water supply. And also there should be a disposable napkin should be available, or hot air dryer should be available to dry their hands after doing the hand washing. So this is the hand washing and gowning area before the special care neonatal units. A hand washing sink should be provided within 20 feet, that is 6 meters of every newborn bed. A sink should be large and deep, that is 24-inch wide, 16 front and back is 10-inch deep. Antiseptic sanitizing solution, that is sterilium, can be used for disinfection of hands in between the babies. For doing any procedures, for each and every time you cannot go and do the hand washing procedures. So to avoid that time duration, we are using the sterilium. In between the babies, you can use the sterilium to do antiseptic sanitizing solutions in order to prevent the cross infection between the babies. Next is preparation for intravenous fluid. Before administering the fluid or medication to the babies, we have to prepare the fluid. Either you have to warm the fluid, or you have to add on any medications, or you have to extract any content of fluid from that. For that purpose, you should have a separate bay for the intrafluids administration. And even you have to do a parenteral and nutritional formulations. Enteral feed is being prepared, medication is being prepared, and a proper laminar flow should be there in that particular intravenous fluid area. Proper lighting should be there. Next is the very important is nurses station. So nurses station should have a proximity towards looking or examination of all the babies from the nurses station. So nurses station is a charting area for the nurses, and residents should be located in a central area where all the babies can be visualized. And newborn charts, hospital forms, computer terminals, telephone lines should be located in this area. It is preferable to use electronic medical recordings of clinical notes and retrieval of laboratory reports. So nowadays in many hospitals we are using the electronic medical records, because when we just search the baby's IP number, we will be able to know where and all the caregiver has went for the diagnostic purposes, what all the recent diagnosis have done. Everything can be identified when we maintain the electronic medical record. Next is clean utility and soiled utility holding rooms. So clean utility rooms and the soil utility rooms should have a different base. So they should not be mingled together, because it will again cause an infection in a cleaned area. So cleaned utility area should be in a different way, and the soiled utility area should be in different way. So the soiled linens, soiled pillow covers, everything should be in a different areas in order to do the proper cleaning and sterilization. Next is growing nursery. So there should be a separate transitional care is being required for the high risk babies. So the mothers, before they are being discharged from the hospitals, there should be a separate area for that. Next is the entry of the visitors to that particular transitional area should be restricted, and facilities for vitals monitoring and weighing the babies should be available in this transitional care room for growing the nursery. The growing nursery is used with advantage for educating the caregivers So this is the transitional care for the high risk newborn babies. So when we compare with level 2 and level 3 care, in level 2 care there will be access for the visitors to go and visit the babies for giving expressed breast milk or doing kangaroo mother care, and even for a visit to see their babies. But in this transitional care, the high risk newborns, the visitors are being avoided in order to prevent the infection in the babies. Next is lighting. Yes, of course, in a special care neonatal units, a proper lighting should be placed, that is well illuminated and painted. The painting should be in a white in color. Then only when the light projects on the wall and the visual examination of the health personnel on the babies will be very clear. So you can rule out the discoloration of the skin. If we are using different colors means it will be very difficult for us to identify their visual examination of the skin, that is skin color, everything. So mainly we can identify the hyperbilirubinemia by the white walls and lights. Next is temperature. Ideal temperature should be maintained in the special care neonatal units between 26 to 28 degrees Celsius, that is about 78.8 to 82.4 degree Fahrenheit, in order to minimize the effects of thermal stress on the babies. So you can also use a centralized air conditioning having temperature control knobs in the nursery. Next is acoustic features. Other features like ventilation system, incubators, air compressors, suction pumps, and many other devices used in the nursery produce noises. So when there is a noise, there is a chance of having a physiological and behavioral disturbance in the baby and sleep disturbances in the baby. They will be having a cry, and also startle reflex due to a sudden sound will be there. In order to avoid that, in place of sound you can use the alarm lights. Next is like you can also have effective soundproofing for ceilings, walls, doors and floor when a new nursery is designed. Telephone rings and equipment alarm should be replaced by blinking light. So instead of air compressors, centralize the source of compressed air and oxygen, and suction should be provided. And decibel meter should be installed to monitor the sound level in the nursery. And instead of just using this equipment sounds, you can have a soothing effect of soothing sounds like melodious songs, melodious BGM, or the parent's voice in each and every newborn's place can be placed. That are the other features, that is acoustic features of the special care neonatal units. Next we will be seeing about the electrical outlet. So each infant must be provided with at least 8 electrical outlet for easy access to the electricals. For example, 4 should be a 5 amperes and another 4 should be 15 amperes. The use of adapters and extension board should be discouraged. Next is nursing care. The National Neonatology Forum of India has recommended that at least one trained nurse should be allocated to provide coverage to 4 babies in the special care neonatal unit. The allowance should be kept for additional 25% staff to provide for the exigencies of day off and leave. Therefore, 8 bedded special care neonatal unit, 8 nurses should be sanctioned to ensure availability of 2 nurses in each shift, along with one additional sister in charge in the morning shift, to have a smooth functioning and to render the quality nursing and also have a continuous comprehensive nursing care. You have to provide a 25% extra of staff allocation to the special care neonatal units. For example, if you are having 8 bedded hospital means we have to provide 8 nurses in each shift. Medical care is the independent senior resident and 1 junior resident should be around the clock for every 8 babies requiring special care. The resident doctor must work in these units for at least 3 months to maintain the continuity of medical care. All deliveries in the hospitals should preferably be attended by the physicians trained in the care of newborn. So the doctors, the physicians who is being functioning in the newborn unit also have to function in the hospital unit where the delivery is being conducted. A biomedical technician or a link person is essential to maintain a liaison with suppliers of equipment to ensure their smooth functioning, prevent the breakdowns and reduce the downtime. The resident staff and nurses working in the neonatal intensive care unit must be trained to properly handle and use the equipment. So before, as a multi-specialty hospital being investing on the equipments, they should give the proper training to the nurses, and also the biomedical technician should be present in the hospital in order to see any failures in the equipment, or for the smooth functioning of the equipment, or if the equipment requires any contamination. Everything should be carried out in the hospitals. During the last 2 to 3 decades, there have been increase in the advancement of technologies, either equipment or the drugs or medications, diagnostic equipments, everything. So before the hospital is being investing on that particular equipment on a very large amount, they should give a proper training to all the personnel who's going to handle that equipment before being coming into the function in the hospitals. So that is the main need for each and every equipment being introduced in the hospitals. The proper training is given for all the nurses, doctors, and the additional this auxiliary nurses, midwiferys, everyone. We are giving the training on the equipments. That is the main. So machines cannot replace the men. The best monitors with us are dedicated nurses and senior resident doctors involved in the care of newborn babies with their observational skills sharpened by experience. Therefore, they need a continued in-service training. So when we have a continuous training in our work, we'll be easily handling on the babies with the proper experience and proper competence, professional knowledge. Next is equipment. So what are the equipments being available in the special care neonatal unit is emergency tray should be available in each infant care unit of special care neonatal unit, containing ambu bag and mask, infant laryngoscope, tracheal tubes of different sizes, sterile suction catheters, oral mucus suction traps, and emergency drugs. And bag and mask resuscitator, that is maybe self-inflating bag of 250 to 500, and for laryngoscope there should have a appropriate size of the blade should be present, oxygen and suction facility should be present, and every equipment should be there. That is, incubators should be there. The incubators are provided for the ideal micro environment for high risk babies. About 1/3 of nursery beds should comprise of incubators, and the sensory stimuli like light, sound, touch, and pain should be kept to the incubators. Next is radiant warmer. A skin probe is applied over the liver area in the epigastrium and shielded with a foil covered foam adhesive pad. When a baby is in nursed prone, skin probe is applied over the flank region. The probe should not be allowed to come in contact with the bed. So these are the equipments being present in the special care neonatal units. That is incubators, radiant warmer. Next is phototherapy unit. So phototherapy unit is for especially for the babies with hyperbilirubinemia. So for that babies we have to provide the safe and effective method of treatment for neonatal hyperbilirubinemia. And the infant is exposed under the portable or fixed blue light source, that is 425 to 475 nanometer, kept at a distance of about 18 inches, that is 45 centimeter from the skin, and the light source designed to give a radiance of a particular unit. Next is courtside laboratory facilities. For each and every time you cannot send the specimens to the laboratory that is which is far away for the other wards. So in the special care neonatal units there should be a separate laboratory place to do all these diagnosis purposes, either blood investigations or urine investigations or stool investigations. For that purpose a courtside laboratory facility should be available. So far we have discussed about the organization, that is physical structure of special care neonatal units. If you have any doubt, kindly drop down in the comment box. Thank you for watching. Kindly like, share and subscribe, and have a continuous learning in your profession. Thank you for watching.